There are over 50 different hypertension drugs available, and one of the reasons why there are so many different choices on the market is because people respond differently to different drugs. And in a way that's not too surprising. We measure hypertension in a very simple way. We just look at systolic and diastolic blood pressure. But there are many different reasons underlying patients' raised blood pressure, and each of those might need a different drug to treat it properly. And we also know that people respond differently to drugs by age and by ethnicity. And when you put all that different information together, it makes it quite challenging to treat a patient with hypertension. Currently, doctors use an informed guessing game as to which drug they need to start with. And they can make the choice of that drug based on some very simple information like a patient's age or a patient's ethnicity. But that's clearly not enough. Many patients have to go on and try several different drugs. And in this era of personalised medicine, it would be really useful if we could base our decision-making, our prescribing decisions on much more personalised information than just age or ethnicity. We know that hypertension drugs work differently in people of different ethnicity. So for example, patients of Black or African ethnicity tend to respond better to diuretics. But that classification of ethnicity is a very simple one. It just puts people into boxes, or Black or white ethnicity, just like ticking the boxes on our census forms, for example. And that's a very poor way to capture a very rich phenotype like what people's ethnicity is. So for many people, they may not have a single ethnicity, that their ancestry may be a mix of Black and white, of Asian, of African ethnicity. And so putting people into very simple boxes doesn't capture very much of that information. So to get information on people's genetic ancestry, we need to take a blood sample from them, we need to test their genetics in the laboratory, just to get information on hundreds and thousands of sites in the DNA where people differ from each other. And we use that information on patients with hypertension, and we compare that between patients and with other data sets that we have externally, and we can then calculate, using very detailed mathematical models, what proportion of a person's ancestry comes from different ethnic groups. So we would then be able to say that a patient has, say, 53% Black African ancestry and 47% white European ancestry. And the real question that we're interested in here is, does having that detailed level of ancestry, specific proportions that come from different population groups around the world, does that information allow us to get a better prescribing for hypertension medication?